Welcome, dear colleagues. I am Dr. Ashraf Radwan, a fellow of Montpellier University, France, and the medical director of Maghrabi Eye Center, Medina Road, Jeddah, Kingdom of Saudi Arabia. Today, we are going to discuss together the management of the retinal vein occlusions. Retinal vein occlusion is the second most common cause of reduced vision due to retinal vascular disease after diabetic retinopathy. Branch retinal vein occlusion occurring 2 to 3 times more than the central retinal vein occlusion. The incidence of retinal vein occlusion reports to be 0.7% between the age of 49 to 60 years old, and it increases up to 4.6% after the age of 80 years. The branch retinal vein occlusion occurs at the retinal arteriovenous anastomosis or crossing. هعيد تاني هنا في السلايد دي برضو. Branch retinal vein occlusion occurs at the retinal arteriovenous crossing, where they share a common adventitia. Compression by the arteries, it makes a turbulent flow, especially in atherosclerotic patients, that leads to endothelial damage and a thrombus formation and the development of the branch vein occlusion. Central retinal vein occlusion may be compressed by the central retinal artery at the lamina cribrosa, or the other predisposing factors is the presence of degenerative or inflammatory disease in the central retinal vein wall itself, or a hemodynamic factor such as hypotension and blood dyscrasis. These factors, it leads to the stagnation of the blood in the veins that leads to a thrombus formation. Most central retinal vein occlusions are at the lamina cribrosa or just posterior to it. The perfuse type of the central retinal vein occlusion occurs more posterior to the lamina cribrosa, where it is rich in collaterals. The risk factors for the vein occlusions. Ophthalmological risk factors, as we can see, is a glaucoma. While the systemic risk factors, we have the hypertension and the cardiovascular diseases. As we know from the statistics, that 64% of patients over 50 years are hypertensive. 64% of patients representing a vein occlusions. Over 50 years, all these have a hypertension. And the hyperlipidemia and hypercholesterolemia, these are the most predisposing factor for patient presenting a retinal vein occlusion under 50 years old. 71.4% of all patients do have hypercholesterolemia of the patient presenting with a vein occlusion less than 50 years old. Diabetes mellitus is one of the important risk factors for vein occlusions. We have other risk factors like obesity, smoking, and contraceptive pills, and optic disc vasculitis, or are all these represents the risk factors, especially in younger patients. What our way for the diagnosis of the retinal vein occlusions? We have either we do the slit lamp examination, fluorescein angiography, optical coherence tomography, as you will see in the image now. Here we have a patient having a left central retinal vein occlusion with very clear engorged congested veins, intraretinal hemorrhages, and hyperemic disc in the left eye. We did the fluorescein angiography. There is a late severe cystoid macular edema with no retinal capillary dropout or ischemia, and it is very clear the engorged veins and the cystoid macular edema in the late time. So it is an edematous central retinal vein occlusion in the left eye. It is very clear in the late time with important cystoid macular edema. Another example here in the left eye also, this patient having a dilated tortuous veins with hard exudates and hemorrhages in the posterior pole. We did the fluorescein angiography for these patients. We can see an important capillary dropout in the nasal and superior and inferior quadrants of the retina with a late cystoid macular edema. But we have to notice here on the optic disc the presence of a pre-retinal neovascularization. So this is it is an ischemic central retinal vein occlusion complicated by a pre-retinal neovascularization. Another example here we can see in the right eye, this patient having a dots of hemorrhages, cotton wool spots, taking the place in the superior temporal arcade. It is a superior temporal branch retinal vein occlusion. Is it ischemic or no? Let us to see with the fluorescein angiography. Yes, it is very clear. We have a capillary non-perfusion interesting the superior temporal arcade with a late mild edema in the macula in the upper part, partial cystoid macular edema, as it is very clear in this image. So by diagnosis, it is an ischemic central retinal vein occlusion complicated by partial cystoid macular edema. This is another example of a superior temporal ischemic branch retinal vein occlusion, but we have to notice the presence of a pre-retinal neovascularization, which is a characteristic complication if this patient was not well treated with laser after being diagnosed. So this patient having this ischemia, it can develop a pre-retinal neovascularization like a central retinal vein occlusion. So we should not take a branch vein occlusion, especially the ischemic type, lightly. As we can see in this image, it could develop a pre-retinal neovascularization. It can go up to a neovascular glaucoma, and it could make a vitreous hemorrhage, traction detachment, a lot of complications. So this is an ischemic branch retinal vein occlusion complicated by a pre-retinal neovascularization. Very clear in the image here. The role of OCT in retinal vein occlusion. We can see here in the central retinal vein occlusion, we are sure that there is a certain form of edema in the macula, but we cannot measure it. With fluorescein angiography, yes, there is a cystoid macular edema. How many microns is it? We don't know. It is an edematous central retinal vein occlusion. It is not an ischemic form. Let us to see with the OCT. This is a huge cystoid macular edema, especially in the image in the left. This is a pre-treatment. While in the left image, it is after a 3 intravitreal anti-VEGF injection, and we can see how much the macula is dry, and it is absorbed the severe cystoid macular edema in it. So the OCT first, it diagnoses the thickness, and it can follow this patient for the improvement after the treatment, and it helps us to judge for the continuation of the medication or no, and to compare the two results between the pre-treatment and the post-treatment. As you can see here, a comparative image between pre-treatment and post-treatment. And this presents the advantage of OCT over it. This is another example of central retinal vein occlusion with a severe cystoid macular edema pre-treatment. And this is a status post intravitreal anti-VEGF for the same patient, and we can see how much the cystoid macular edema is absorbed, and the macula returns to a normal anatomical function. Here another branch retinal vein occlusion, a very small superior temporal branch retinal vein occlusion, but associated with a partial cystoid macular edema. Let us to see with the OCT. Yes, it is very clear. We can see and we can measure how many microns the thickness of the foveal cyst. And this is after 2 intravitreal anti-VEGF. We can see there is a remaining very small microcystic spaces in the fovea that can be solved with a third injection or with a few shots of laser, focal laser over this area. The management of retinal vein occlusion, first we have to consider the medical management, as we have to treat this patient if he had a hypertension or if he has a central cardiovascular systemic disease. It has to be treated. If he is diabetic, he has to be well controlled. Hyperlipidemia and thrombophilia, it has to be controlled and treated, in fact, if possible. To prevent a systemic event, the medical management is very important to avoid any attacks of vein occlusions anywhere in the body and to reduce the risk of venous occlusion, especially in the fellow eye. For ophthalmological management in retinal vein occlusion, we have three ways of interference, either by intravitreal injections or intravitreal implants or a laser photocoagulation. In fact, we have for intravitreal injections the presence of the intravitreal anti-VEGF. As all of you know, that we have the bevacizumab or the Avastin, and it is used off-label, as you know, and the ranibizumab, which is FDA approved and Saudi FDA approved to be used for retinal vein occlusions. These are the anti-VEGF, and on the way we have other anti-VEGF like the aflibercept or the Eylea on the way. It is approved, FDA approved all over the world, but still on process here in Saudi Arabia. These are the anti-VEGF available in the markets, but we have still certain roles for intravitreal steroids in persistent severe cystoid macular edema associated with the retinal vein occlusion. We still use the triamcinolone acetonide or the Kinalog as an intravitreal injection. We can go for the implants like the dexamethasone or the Ozurdex Allergan. It is an implant. We'll explain each of these ways of management in details in the next slides. And we have the laser photocoagulation, either the regular laser photocoagulation or the micropulse laser. The intravitreal injections, as we have mentioned, now we have the anti-VEGF, the bevacizumab or the Avastin, and ranibizumab or the Lucentis, and the intravitreal steroids, the triamcinolone acetonide. Both ranibizumab and bevacizumab are humanized monoclonal antibodies directed as anti-vascular endothelial growth factors proteins to help in the absorption of the macular edema caused by the vein occlusions. The main difference between both of them is that, as you know, the main monoclonal antibody, if we activate, we take a small portion of it and is humanized, and it is used as a ranibizumab particle with a small fragment, and the body weight of this fragment is around 48 kilodalton, compared to the Avastin or the bevacizumab, where it is just a humanized whole antibody. So the size and the body weight of this antibody is 148 kilodalton, and this differentiate one of the differentiates both of them, the Lucentis being smaller in size compared to the bevacizumab. The way of injection of anti-VEGF, as you know, it is used in the OR, complete sterile condition. We use a topical anesthesia, no injections. We use usually a 30 gauge needle, and it is inserted 3.5 to 4 millimeter from the limbus, as it is seen in the diagram here. The dose of intravitreal anti-VEGF, in Avastin we use 0.05 cc, which represents 1.25 milligram. The Lucentis we use 0.05 cc, which represents 0.5 milligram. In fact, states usually they use up till now a less concentration, but here in Saudi Arabia we are using the 0.5 milligram. The mode of action of anti-VEGF based on two properties: anti-angiogenic effect through blocking the vascular endothelial growth factor A, so inhibiting the neovascularization, and on the other hand, having the possibility of causing anti-permeability effect. It promotes the fluid to be reabsorbed, so it helps to resolve the edema. Here an ischemic branch retinal vein occlusion, as we see a capillary dropout with a partial cystoid macular edema, and the vision is 0.05. With OCT, there is an important edema interesting the superior temporal arcade and important cyst, foveal cyst. This is after 2 intravitreal anti-VEGF and a scatter laser over the ischemic area. In fact, after the absorption of the edema, the vision of this patient grows up to 0.5. And the edema is too much resolved. He is just in need for one more intravitreal anti-VEGF injection to completely dry this macula. This is a comparative image between the left eye pre-treatment and post-treatment of that patient, and how much it is absorbed, with a residual mild edema that will be a matter of intravitreal injection of anti-VEGF. We go to the another category, which is intravitreal steroids, the triamcinolone acetonide or the Kinalog. The dose used is 0.1 cc, represents 4 milligram, followed by paracentesis if we give it with any anti-VEGF. The triamcinolone acetonide or the Kinalog, it is a corticosteroid hormone, glucocorticoid. The Kinalog reduces the swelling and the inflammation in the eye. Intravitreal Kinalog proven to be very quiet and safe, but it has a lot of adverse reactions. The most important adverse reactions are the cataract, which represents 50% of the cases, and ocular hypertension that could happen in 50% also of the cases. Glaucoma that needs interference with medication represents 30% of the cases. Most of them are responding to medication, but there is 5% that needs surgical interference. Regular post-intravitreal injection and subconjunctival hemorrhage, which is one of the characteristics of any intravitreal injection, that it can happen with it. The Ozurdex, which is intravitreal implant, it is another idea by injecting steroids inside the eye. Intravitreal biodegradable dexamethasone implant, which represents 0.7 milligram. The advantage of the Ozurdex, it is in the drug delivery technique, which is called as a Novadur. This implant, it slowly dissolves in the vitreous, releasing dexamethasone, so there is no need to remove this implant later on from the vitreous. It dissolves by itself and by releasing dexamethasone every day. The indications for Ozurdex are the presence of macular edema, especially for retinal vein occlusions and the non-infectious uveitis. So it is one of the main ways of treatment in the macular edema caused by the retinal vein occlusions. The contraindications of the use of Ozurdex are the presence of any glaucoma, especially if it is advanced. It is totally and completely contraindicated. The ocular and periocular infections like active epithelial herpes simplex keratitis or dendritic keratitis, vaccinia, varicella, microbacteria and fungal infections, these represents a definite contraindications for the use of Ozurdex. but still it has an adverse reactions or adverse side effects compared to the triamcinolone. It is less, but still present. We have the ocular hypertension that represents 25% of the cases, subconjunctival hemorrhage 22%, eye pain 8%, conjunctival hyperemia 7%, cataract it is 5% compared to the 50% in triamcinolone, vitreous detachment 2%, and headache 4%. The increased intraocular pressure with Ozurdex, it peaked at approximately 8 weeks. So after 2 months, it is usually we could have a peak of increased intraocular pressure with Ozurdex. 1% of the patients who received Ozurdex required surgical procedures for management of elevated intraocular pressure. This is an example of a patient having central retinal vein occlusion before giving him Ozurdex, having a severe cystoid macular edema, and this is after complete resolution of the edema with Ozurdex. Laser photocoagulation. The indication of laser treatment by the use of the focal laser, it is used just only for the residual macular edema in branch retinal vein occlusion. We don't use it in central retinal vein occlusion. It is just for branch retinal vein occlusion, and not from the start. It is just for the residual mild edema. We can interfere by making focal laser if it doesn't stop after repeated injection with intravitreal anti-VEGF. The scatter laser, it is indicated only in cases having an ischemic central retinal vein occlusion or branch retinal vein occlusion to protect the eye from going for further complications like retinal neovascularization or neovascular glaucoma later on. So as a conclusion, retinal vein occlusion is the second most common cause of reduced vision after diabetic retinopathy. Fluorescein angiography and OCT present the main tools for diagnosis, while OCT continue in the follow-up for the patients. Intravitreal anti-VEGF presents a key word in treatment of retinal vein occlusions. Intravitreal steroids and laser treatment still have a place in management of retinal vein occlusions. Thank you.